Ultrasonography of intrauterine device, part 2. Malpositioned IUD. The malpositioned IUD can be considered a spectrum of abnormal positioning. 1. Expulsion. 2. Perforation. 3. Displacement. 4. Embedment. Malposition is more often associated with symptoms of pain and excess bleeding, but can be asymptomatic. It is suspected clinically when there is shortening, lengthening, or absence of retrieval strength on pelvic exam. This table includes the types of malpositioned intrauterine devices and their definitions. Expulsion means passage either partially or completely through the external cervical os. Displacement means rotation or inferior positioning in the lower uterine segment or cervix. Embedment means penetration of the myometrium without extension through the serosa. Perforation means penetration through both the myometrium and the serosa, partially or completely. I will explain each one in details. Number 1. Expulsion. The expelled IUD has passed inferiorly, either partially or completely, through the external cervical os. The expulsion risk is greatest in the first year of use, and the expulsion rate is highest with immediate postpartum placement after vaginal delivery. When the expelled device has been identified or is seen on physical exam, expulsion can be managed without imaging. However, in cases of absent retrieval strength without witness of the expelled device, pelvic ultrasonography should be performed to evaluate the IUD position. If no IUD is identified by ultrasonography, an abdominal radiograph is recommended to exclude perforation and intraperitoneal migration. Management of partially expelled IUD includes removal with a pair of alligator forceps or an IUD hook, generally in an outpatient setting. Number 2. Displacement. Displacement refers to any IUD that is rotated from the normal transverse position or located away from the fundus and within the lower uterine segment or cervix. Early studies defined displacement as a distance of more than 3 mm between the IUD and the uterine fundus, which was initially thought to be associated with a high risk of expulsion. However, more recent studies have shown that a majority of low IUDs move to a fundal position within a few months. This image shows incidentally detected displaced intrauterine device in a 38-year-old female. A sagittal transvaginal sonogram demonstrates the echogenic IUD stem within the cervix. B. Axial T1 weighted magnetic resonance image shows the low signal IUD stem within the cervix. The question of efficacy guides the management of the displaced IUD. Although no formal analysis has been performed at our institution, we have experienced both isolated cases of early intrauterine pregnancy and ruptured ectopic pregnancy with displaced cervical IUDs. A displaced copper IUD has decreased efficacy. However, a displaced hormone-releasing IUD is equally effective as a properly positioned one. Any decreased efficacy of a displaced IUD must be weighted against the very real risk of pregnancy if the displaced IUD is removed without the implementation of an alternative form of contraception. A recent retrospective study reported a 2-fold increased pregnancy rate in patients with malpositioned IUDs, but all resulted from removed IUDs. No pregnancies occurred with a displaced IUD in situ. Because of this risk and the differences in efficacy, some researchers advocate for the removal of displaced copper IUDs but not hormone-releasing devices in asymptomatic patients. Regardless, findings of a malpositioned IUD should be communicated to the referring physician. This image shows displaced intrauterine device in a 23 years old female with positive pregnancy test despite intrauterine device. A sagittal transvaginal sonogram shows malpositioned IUD within the lower uterine segment and the cervix. B. An intrauterine pregnancy is seen within the uterine fundus. C. Transverse transvaginal sonogram shows the relationship between the low-lying IUD within the cervix and the gestational sac within the uterine fundus. The intrauterine device was removed without incident. The pregnancy resulted in a normal, full-term delivery without adverse complications. This picture shows displaced and embedded IUD with early pregnancy in a 24 years old female with acute abdominal pain and positive pregnancy test. A sagittal transvaginal sonogram shows IUD stem displaced within the lower uterine segment and embedded in the posterior myometrium and the gestational sac in the uterine fundus. B. Zoomed in transvaginal sonogram of the gestational sac clearly shows a double decidual sac sign. Rising human chorionic gonadotropin was consistent with pregnancy, although the outcome of the pregnancy is unknown. Number 3. Embedment. Embedment refers to the penetration of the myometrium by the arm or stem of the IUD without extension through the serosa. When involving the stem, this may be obvious on standard 2D transvaginal ultrasound, but in cases of more subtle arm embedment, 3D coronal images allow for better detection. With the added sensitivity of 3D techniques, the incidence of embedment was found to be high. Extension into the myometrium is thought to occur at the time of insertion. When these findings are associated with symptoms of pain or abnormal bleeding, IUD removal is recommended. Often, embedment occurs in combination with displacement, which also leads to the same management decisions based on efficacy as those previously discussed. This image shows embedded IUD in a 24 years old female with menorrhagia and unsuccessful attempts at IUD removal. A sagittal transvaginal sonogram shows inferior displacement of a copper IUD within the cervix. B. Transverse transvaginal sonogram of the cervix shows the arms of the IUD extending into the cervical wall. C. Three-dimensional coronal sonogram better demonstrates both arms embedded within the myometrium. The IUD was subsequently removed under anesthesia. This image shows embedded intrauterine device in a 31 years old female presents with the absence of retrieval strength. A sagittal transvaginal sonogram shows the IUD within the endometrial canal. B. Three-dimensional coronal sonogram more clearly demonstrates the IUD obliquely tilted and embedded in the left uterine myometrium. The echogenic retrieval strength is seen within the endometrial canal. Number 4. Perforation. The perforated IUD may penetrate through the serosa either partially or completely. with migration into the intraperitoneal cavity. As with embedment, perforation occurs at the time of insertion. Perforation through the serosa occurs in 1 to 2 cases per 1,000 and is more often seen with inexperienced operators, with early postpartum placement, and in women with either few prior pregnancies or multiple miscarriages. This image shows partially perforated intrauterine device in a 43-year-old female with shortened retrieval strings. A sagittal transvaginal sonogram shows the stem extending through the myometrium of the posterior wall. B transverse transvaginal sonogram shows the arms extending outside the serosa. C and D, midline C and left lateral D, sagittal magnetic resonance images demonstrate correlated findings of the low signal IUD coursing through the posterior myometrium with the arms extending through the serosa. This image shows complete IUD perforation with intraperitoneal migration in a 30-year-old female with absent retrieval strength and right upper quadrant abdominal pain. A transvaginal ultrasonography was unable to identify an IUD within the uterus or cervix. B frontal radiograph of the abdomen and pelvis shows the IUD in the right upper quadrant. C. Contrast-enhanced CT was ordered to assess for bowel injury given the patient's abdominal pain. Coronal CT image demonstrates the IUD within the omentum without evidence of bowel injury. The IUD was removed laparoscopically and was found to be entangled within the greater omentum. Adhesions that form as a result of a foreign body reaction to the perforated IUD can involve the fallopian tubes and result in decreased fertility. Cases of complete perforation can also rarely be associated with injury to adjacent structures, most often the bowel. If an IUD can't be identified on initial ultrasonography, abdominal radiographs are required to locate the IUD. Cross-sectional imaging can be used for surgical planning and to evaluate for complications such as abscess formation or bowel injury. Management includes surgical removal, which can usually be done laparoscopically. Uncommon IUD complications. Number 1. Fragmentation. IUD may rarely be broken during expulsion or removal, including embedded retrieval strings. Few data are available on the long-term effects of retained strings or pieces of devices, and no clear management guidelines have been established. Manual vacuum aspiration may be helpful in IUD removal in cases of embedment, otherwise surgery may be required. This image shows retained intrauterine device retrieval string in a 24-year-old female with crampy pelvic pain and a history of IUD removal approximately a year ago. Sagittal A and transverse B transvaginal ultrasonography of the cervix demonstrates a partially fragmented linear echogenic structure along the posterior wall of the cervix. The patient had a history of removal of an embedded IUD with portions of the retrieval strings left behind. Number 2. Calcification. Incrustation, the formation of calcium carbonate deposits on or near the IUD, is a well-described phenomena that can be demonstrated as uneven echoes surrounding the normal IUD echoes. The clinical significance of these calcifications is unclear. Early concern over associated inflammatory complications haven't been further investigated. This image shows Calcifications associated with the intrauterine device in a 39-year-old female with pelvic pain and a history of a levonorgestrel releasing IUD placed approximately a year ago. A sagittal transvaginal sonogram shows IUD probably positioned midline within the uterine cavity. B and C, sagittal B and transverse C, transvaginal sonogram shows a coarse echogenic shadowing structure within the endometrial cavity adjacent to the IUD. D. The calcification is seen faintly near the T-shaped IUD on the axial maximum intensity projection reconstruction computed tomography. Mimics of IUD. Occasionally, linear echogenic intrauterine structures can be mistaken for an IUD. Retained fetal bone fragments are rare sequelae of spontaneous or induced abortions. Ultrasonography findings include linear or angular echogenic shadowing structures within the uterine cavity or myometrium. In the absence of a clear history, this finding may be misinterpreted as an IUD on ultrasonography.